You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Hello, and welcome to this episode of International Perspectives on Dry Eye Disease. I'm your host, Laura Periman. In this series, clinicians from around the world are going to comment on some of the under-discussed aspects of dry eye disease that are sometimes glossed over. For our final episode in this mini-series, we'll examine the clinical journey of a patient with dry eye disease. This is the final episode of our first season in this mini-series. And if you like what you've heard in this episode, go back and listen to the first two episodes, which can be found earlier in your podcast feed. This episode is going to be a little bit different from our first two. In this episode, we'll listen to a previously recorded interview performed by our producer. After that, we'll take a quick break and allow two practicing clinicians to comment on what they heard from the patient. But first, let's introduce our wonderful panelists. Dr. José Gomes, who is professor of ophthalmology at the Federal University in Sao Paulo, Brazil. Dr. Gomes, thanks for joining us.
Thank you, Laura. Thank you for the opportunity to be here answering about dry eye.
Excellent. And also I'd like to welcome Dr. James Wolffsohn, who is professor and head of optometry at Aston University in Birmingham, United Kingdom. Professor Wolffsohn, thanks for coming on the show.
Thank you, Laura. My pleasure to join you today.
We're going to hear from a patient who we'll call Jessica. We've changed her name for privacy purposes. Jessica spoke with our producer, who clipped a few segments of her interview for us to listen and respond to. A little bit of background about Jessica. Jessica is in her 30s and she lives in central Washington state. She is highly myopic and wore contacts daily starting from her teenage years. And it worked well for about 15 years. But then she started experiencing some ocular discomfort. Her primary eye care provider asked her to take a break from contact lens wear, but she was still uncomfortable and getting worse. Let's hear from Jessica.
So the first symptom that really started bugging me was the burning. I had a lot of burning in my eyes, and nothing really triggered it. The burning is what first kind of startled me per se. I didn't know, why they were hurting so bad, but then they started feeling so dry. And it's a feeling you can't really describe. Like, you can say my eyes are dry, but this was dry. I mean, I was putting in artificial tears probably every 30 minutes, and that included during the night. So when I started going through a box of artificial tears, I think there were 30 in the box. I'd finish those probably in 2 days. That's when I was like, okay, this is not working. This is getting worse.
Her primary eye doctor told her to switch to a different over-the-counter artificial tear, which wasn't effective. During this time, Jessica started to experience severe photophobia, which scared her enough that she went to the ER. She was advised to follow up with her eye doctor, which she did. He recommended a steroid eye drop.
And I thought, okay, great. The steroid drop, this is what I need. This is going to fix it. It didn't. I was on the steroid drop for about a week, and things were not getting any better. Still doing the tears. I wasn't sleeping. I was up all night putting in these artificial tears because nighttime seemed to be the worst for my eyes. I was going to bed probably about 7 o'clock because I just couldn't keep them open. They were killing me. They hurt so bad. I couldn't go to my son's soccer games. I couldn't do anything. My life literally revolved around my eyeballs at that point. And so I went back in, and he thought, well, you know what? Your eyes look okay, but I'm going to refer you to another specialist just to make sure we're not missing anything. So I thought, okay, let's do that. I was worried about the wait time, to get into the specialist, but luckily it was pretty quick.
Let's talk about our approach to patients with these types of quick onset and severe symptoms. Sometimes by the time they reach our clinics, they're frustrated and have been unable to find relief. Well, Jessica certainly has a compelling story, and I think it's moved each of us. Now let's talk a little bit about, from an expert dry eye doctor perspective, what stood out in her history, and do you see patients like this?
Yeah, certainly for me, this is a very typical patient story. So that, as you say, frustration that they've tried their best to get treatment for their eyes, that long journey, extreme discomfort, and the challenge of using artificial tears, which is the mainstay of dry eye therapy, but does not fully answer a lot of cases. It does sound like she was compliant, and of course that's really important with artificial tears. 4 times a day for a month as a sort of minimum to really see whether they're going to work. But actually, we need to then dig deeper as detectives if that's not helping her.
I agree. Gomes, what stood out in her story for you?
Well, Laura, this is, as James mentioned, a very typical case. And two facts really caught my attention. First, it's a 30-year-old woman, and we know that the prevalence of dry eye is more common in women after 30s, when start some changes in the hormones, especially in women. And the second point that caught my attention is that the contact lens use. It looks like she started to feel discomfort when she started to use contact lens. And then she started to use the lubricants and didn't get better, went to the steroids. So something also that was induced by the contact lens, or maybe she had dry eye, and with the contact lens, it just changed the situation, the microenvironment of the ocular surface, and she started to feel the problems. If it's related to contact lens, one thing that need to be done first is to review the contact lens fitting, the type of contact lens, and we know that especially soft contact lens, we have better materials that can be more comfortable for dry eye patients, but we also need to see if the contact lens is well fitted, if it's not too tight, and if there's a problem with the contact lens. The second point is that as we see in many cases of dry eye, the patient started to develop the disease, and then it starts a chronic process of inflammation. And this really makes the situation a little worse, because then you need to work not only with the lubrication, but also with the inflammation that many of these patients develop after the situation gets chronic. And what caught my attention in this patient as well is that she started using a steroid and that it didn't get better. So as James mentioned, we need to really investigate all aspects of her situation, the ocular surface, the leads. We need also to take a very deep look in the contact lens fitting to understand better and to get a better approach for this patient.
I wonder if you also run into patients who perhaps overdo it with artificial tears and create what I call a dishpan effect, where there's very little like actual natural nutrition laden protective lacrimal fluid on the surface. Do you run into this?
Yeah, certainly, and not just artificial tears. Quite often people start on the artificial tears and then start adding other things. Often they visit multiple professionals. So by the time you see them, it's really difficult to differentiate what might be working, what might be irritating. And also, I think when you've got that many things to try and juggle, compliance often gets mixed. And so it's really difficult to ascertain whether a particular treatment could work if it was done in isolation, or maybe with a combination of one or two other things, but properly compliant.
And I'm curious what your perspective is on, it sounds like no improvement on a topical steroid. Does that tell you anything about the severity of what's going on, the comorbidities that are contributing to this very severe presentation?
Yes, the fact that the case did not improve with the steroids drop, that makes us to get a little worried, because in many cases, when inflammation comes to dry eye, it usually responds to steroids drops. But in this case, as she didn't get an improvement with steroids, then you need to try to be more careful to review everything. What is she doing? If it's sometimes patients do not tell you exactly everything that she's doing or everything that she's using or the frequency that she's using. So you need to investigate, to go back a little bit and to try to understand what is going on. The second thing that might happen in a few patients is that in a few cases of dry eye, the patients evolve or start to develop a neuropathic pain syndrome, which makes the diagnosis a little more tricky. And then this patient will not improve with any type of lubricant or steroid or anything. You need to try other types of therapies, and that needs to be also investigated. So as James mentioned at the beginning, and I mentioned in the first answer, we really need to go back and check all aspects of the eye examination and try to really ask the good questions about the habits of what this patient is really using, if she's not using anything that could be toxic to the ocular surface. And we cannot forget about the possibility of the neuropathic pain that sometimes gets patients with a lot of symptoms despite of everything that she's trying.
I agree. Thank you for that. James, do you have any other insights or things to add to these excellent presentation?
No, I think that's an excellent summary, but particularly the fact that she's not getting any benefit from the steroids, which is going to dampen down any sort of the inflammatory type effects, suggests that there's something else underlying here that really needs to be looked at. This is more complex than a simple, straight evaporative dry eye case. And so we really do need to do that sort of subclassification and then looking at the other features that can disrupt this very fragile tear film on the ocular surface.
It's important as well, you know, considering the some aspects of this patient. She's a woman, 30 years old. We cannot forget that she's also in the group of Sjogren's syndrome. And so it's very important not only asking, but sometimes if she's not improving it, and if you detect that she has, like a problem of deficiency of the aqueous component, you could never forget about looking for Sjogren's, either asking some tests or even asking some few key questions. For instance, how is the salivary flow? If she's has also feel dry mouth, and maybe interact with a rheumatologist to ask some specific tests, or even a biopsy in case the rheumatologist suspect of Sjogren's syndrome. So this is something that we need to keep in mind, that is a very important disease to investigate, especially in women after the 30s.
Well, I thank you so much for this great discussion so far. Let's take a quick break, and when we get back, we'll continue to hear from Jessica and learn how her workup continued and how she finally found relief. Welcome back to the show. We're joined by two international esteemed guests, Dr. Jose Gomes from Brazil and Dr. James Wolffsohn from the United Kingdom. Back to Jessica's story. She was referred to an ophthalmologist about 90 minutes away from her home. At first, she tried punctal plugs, but they kept falling out. Driving back and forth to her doctor every few days for replacement plugs wasn't sustainable. The ophthalmologist decided to try a course of cyclosporin drops. Let's hear more from Jessica.
And so I thought, great, he said, but it could take up to 6 months to work. And I thought, oh my goodness, like I need relief now, but I'm willing to try anything. So I, filled the prescription, which By the way, eye drops, like prescription eye drops, are expensive. It's insane the amount of money that these eye drops cost. But I was like, I will do anything at this point. So I started the eye drops, and I didn't feel like I had much relief from that. I know that he had told me it would take about 6 months to work, but it could be sooner. I was hoping it would be sooner. But I would say a month, and I wasn't feeling better. And so I made another appointment, and I drove back up there, and I said, okay, like this isn't really helping. And at that point, he said, I've done all that I really know how to do.
That ophthalmologist referred Jessica to a dry eye specialist even further away in Seattle. After her first telehealth appointment with this new specialist, Jessica went in for a consultation. She said that her doctor's compassion was a pleasant surprise, and that during her 5-hour in-person appointment, she learned a lot about ocular anatomy.
She's doing all this testing, and she's telling me, your eyes are so dry, your eyes they're bone dry, and I'm like, thank you, I know. And she's like, I can see it. I can see, why you're in so much pain. And I'm like, oh, thank goodness, like somebody sees it. And from there, it really just started, like my whole routine changed. I left that appointment. I think I drove all the way home with my radio off because my mind was just like spinning of all the things that I had learned and all the things that I was going to be doing. But at that appointment, I actually got a session of IPL.
Jessica is referring, of course, to intense pulsed light, which she continued to receive for several sessions. She also switched from cyclosporin to lifitegrast and received Botox to address newly diagnosed superior limbic keratitis. That specialist also performed a Sjogren's panel and determined that Jessica did indeed have Sjogren's syndrome, which meant some follow-up with a rheumatologist. And the specialist also suggested that Jessica might have sleep apnea.
And I thought, well, I don't have sleep apnea. Like I don't sleep good, but I'm young. Why would I have sleep apnea? And she was like, let's get a sleep study done. So sure enough, I get a sleep study done. And what do you know? I have sleep apnea.
I think this opens us up for a useful discussion about how outside the box thinking might be needed for some of these dry eye patients we see who just aren't finding relief with conventional approaches. Well, I think with some of this workup, we're starting to figure out why Jessica presents with such a severe case of dry eye. James, I'm curious, at what point during a patient history taking, review of past medical history, or during examination and workup, do you start becoming suspicious for systemic conditions, systemic comorbidities?
So I think it is those patients that have had that long journey that have made a really good attempt at some of the basic treatments, and those aren't working for them. And in Jessica's case, there are many of those that she's tried, and it seems that she's been very conscientious about those. Another trigger for me is people traveling those big different distances. So they've tried people locally and that hasn't worked for them. And I'm often very embarrassed when patients do fly across Europe, for example, to visit me, that we can't offer a better service to them more locally. She's certainly willing to try anything. And in her case, it's really good that she was warned that cyclosporin can take 6 months to work. I think that managing of expectations is just so important with our patients. And it is all about that co-management. They're an investigator with us, a really important part of the investigation, because without their cooperation and their insight into their disease, we will struggle to find that opportune treatment for them. Again, in this case, I think that the first ophthalmologist has been very honest to admit that it's come to the end of what he can offer, and has forward referred. And I think that that's really important. And I love the fact that she felt that compassion from the second ophthalmologist. I feel that there's a lot of psychology involved in managing dry eye disease because patients have been through such a journey, and that's almost as important as the physical treatment that we give them. So that keeping the patient informed, and of course in this case, as it turned out, there were lots of comorbidities that needed to be dug out a really long appointment to do that, but what a difference it made to the patient.
Oh, that's great. I totally agree with you. There's so much anxiety that some of our dry eye patients develop, and it's really important to recognize it and address it with compassion and care in order to, so we have a shorthand way of saying it here: to treat the disease, put the mind at ease. And that just means addressing those fear components and letting them know that you're in it for the long haul with them as a dry eye specialist.
Absolutely.
Jose, how often do you see sleep apnea as a comorbidity for dry eye?
I see not that often, but sometimes you need to ask that, and this is a comorbidity that can happen in dry eye patients.
But she's so young, right? I mean, that's unusual to, when you're doing that exam and you see that excessive lid laxity and the papillary conjunctivitis under the lid, and that lacrimal gland sort of coming forward and the lash ptosis. I mean, when I see that triad, I'm thinking, oh boy, this is sleep apnea until proven otherwise, right? But it's unusual to see it in someone so young.
Yeah, exactly. And we always need to remember to examine the lids, the eyelids, the flexibility. That's exactly what you said. It's so important, especially in this patient, because she had superior limbic keratoconjunctivitis as well. Of course, you need to remind about Sjogren's, but of course, sleep apnea and the problems with the lid, and these patients get a lot of trauma during the night, during the sleep time, and we need to remember this differential.
I think that's exactly right. And SLK becomes an interesting, friction syndrome for these patients, and just that it feels like sandpaper is what the patients will tell you, and it looks like sandpaper between the superior conj and the back of the upper lid. It looks like it. I want to talk for a moment just the importance of a good examination and using your vital dye stains like glycine green to look for that suspicious Sjogren's pattern in the interpalpebral conjunctiva, the superior limbic component. The importance of vital dyes and really pushing and pulling on all the lids. I want to speak to that for just a moment.
Yeah, I think dyes are an absolute essential part of what we do. As you say, lissamine green is just so important to really understand the conjunctiva, and as practitioners we need to really watch out because not all lissamine greens are very good at staining. So it's important to get one that really works, so you can very clearly see that marked line, but you can also see the lid wiper and that conjunctival stain. And as you say, that there's some quite diagnostic features of how that staining pattern appears, which gives you again another clue as a clinician as to what you might be needing to investigate further.
Excellent. So just taking the time to listen, taking the time to look, have some compassion for these patients, I think goes a long way. And think deeper, right? What's really going on with this wonderful person?
Yeah, and I think this is a good example that it takes time. That last consultation of the patient, 5 hours, that sounds a very long time. But it does take a good amount of time to do this. This is not something you can do quickly in practice attached to some other consultation. This will take some time and quite often a few appointments to actually unpack fully with a patient and to try a few things, see what works, see what doesn't, and that can help in that sort of investigative procedure.
Love it. I really want to thank Drs. Gomes and Wolffsohn for coming on the show today. And I want to thank the listeners for joining us too on this 3-episode journey. If you only listened to this episode so far, I advise you to go back and get some more bang for your buck by listening to the prior episodes that appear earlier in your podcast feed. For now, my name is Laura Periman in Seattle, Washington. Appreciate you tuning in. Thanks for listening.